going to focus on engaging staff in patient-centered health home practice transformation. I will be your discussion guide for the day. My name is Charlotte Parker, and I am one of the PCHH coaches. I consider myself a teacher and a mentor, and I love to help people innovate new ideas. I have 13 years as a behavioral health program leader and consultant, and 13 years as a community health clinic leader. And along the way, I have also managed to find time to spend 10 years teaching organizational development and leadership theories. So thank you for letting me be your hostess for the day. What we're going to do today is talk a little bit about how you measure success and how you identify what your outcome goals for your patient-centered health home project. And then I want to share with you one of my favorite leadership theories, hoping that it will give you some ideas for how you as a leader can help get your staff engaged in making the required changes. And then we're going to use workflow mapping as an example of how other leaders have engaged their physicians and their staff in implementing performance improvement changes. And I will share with you a couple of successful examples from a couple of different clinics who have used workflow mapping. Then we'll kind of summarize the different theories and talk about some additional resources and references that you can use. But let's start with the beginning, which is really starting with the end. How will you as a leader know that your clinic is truly transformed to being patient-centered? I tried to find a picture that described patient-centered health home, and while I thought this home with a smile was quite charming, I don't really think that that is the patient's perception of a home. In fact, when you talk about patient-centered health home with elderly patients, they sometimes become fearful and go, no, I don't want to go in a nursing home. I say that because my parents are in their 90s and still living at home, and their worst fear is that the family will ask them to go into a nursing home. So when you talk about your patients, that you're making changes, we're in the process of becoming certified as a patient-centered health home. What does that mean? Well, I think most patients identify with the staff, and so I chose here as possibly an image to share. The patient-centered health home is really the patient-centered health home care team. If you have an image that comes to mind, I would love to have an example that is better than what I have shared. So please feel free to email or share your idea of a perfect patient-centered health home by sending to my email address at the end of this presentation. Again, how do you define success? There is considerable research out there of other pioneers who have started the patient-centered health home exercises, and Dr. Crabtree's findings are often referred to. And so he has a list of 7 fundamentals to share, but today we're going to focus just on number 4, and that is evaluation that recognizes that we have to understand how and why physician staff roles do or do not evolve. For example, we know that we just can't stay the same. While patient-centered health home concepts have been rooted in the core of delivery in community health centers, we're being challenged to take those practices to a higher level. And as we look at making changes, that affects everyone. For example, implementing the role of the patient navigator or patient coach might change the location where the patient receives care. Instead of having the medical assistant in the exam room provide all the information to the patient. The patient might be asked to go to a more informal living room setting where they engage with conversations with the patient coach or the patient navigator. And then as the patient coach or navigator takes on a broader role and spends more time with the patient, then that reduces the time the medical assistant spends with the patient, which may be good from a productivity standpoint, that may be sad to both the patient and the medical assistant, who maybe have had a long-standing relationship and enjoy the time that they had teaching and learning together. And so we know that whatever we do, it has the potential for changing the relationship between the patient, the provider, and all the staff members. The old model, back when things were a little more simple, remember I've got over 25 years experience, is that the physician did it all. You had a designated physician. There was a medical assistant that worked side by side with the physician. The receptionist also was designated, and typically a billing clerk. And so there was this core 4-member team that did everything. And that was back when perhaps you had the luxury of spending 30 minutes with every patient, or in some cases 45 minutes or an hour to do a well-woman exam. And now with the physician shortage, it's not always possible for the physicians to spend that much one-on-one time with the patient. So therefore, we have evolved to the model of the physician-led care team. And so some of this research is done and reported out by Dr. Thomas Bodenheimer at the UCSF Center for Excellence in Primary Care. And it's the teamlet model where the physician now has 2 medical assistants instead of 1, so that the roles can be divided, and maybe 1 medical assistant is getting the patient ready for the exam, and the other medical assistant is assisting with the exam or completing the exam after the physician or the clinician has left the room. And we also find that sometimes now we separate the functions of scheduler, that it may be an off-site call center, or it may be a centralized call center, because with electronic health records, it's now possible to do centralized scheduling. So the person who makes the appointment may or may not be on site, or may not be the receptionist that checks them in. And then because it's so timely to process referrals out to the specialist and other specialty care services, we sometimes now have a referral clerk, so it doesn't tie up the time of the physician or the medical assistant. And of course, with the emphasis on care coordination, then we are seeing more registered nurses working in clinics as care managers. And the opportunity to engage patient coaches and navigators who are culturally appropriate and closely aligned with resources in the community, now we've added another member to the care team. And in addition to the billing clerk, we now have enrollment specialists. So you can see how the size of the care team has doubled in many cases. So what happens when you have to tell the physician that you can't spend half an hour with each patient? You can only spend 6 to 8 minutes. Or what happens when you tell the medical assistant they're no longer responsible for processing specialty referrals? Well, in some cases, you get active resistance. As we all know, the implementation of the electronic health record has not been a totally favorable experience for the physicians, as illustrated in this picture that I found here. On the other hand, sometimes you have passive resistance, and staff can just be overwhelmed with the magnitude of the changes. So do you have a staff member who sits here sort of immobilized and overwhelmed by the magnitude of everything that they're having to do differently? So Dr. Crabtree has identified that, our practices are very complex. We have more people, we have more regulations, we have more electronic doodads and devices, and so they're becoming far more complex than the original four-person model where everything was done on paper. And we're finding that a lot of the changes require involving people at the very front end, at the receptionist level, as well as the CEOs interpreting the mandates from top down. And so it's very important that communications and relationships be put at the forefront in order to implement these complex changes. And a leader who can reference proven examples of successful changes can help instill confidence. A leader who is able to say, well, it sounds overwhelming, but let's talk about some of the successes in some of the clinics who have started this process before us. What we know is that community health centers are often located in rural areas or urban areas that may or may not have access to academic types, and people who publish these theories may or may not have practice experience. And so it's helpful then to utilize resources of facilitators to help bridge the gap between academic and researchers and the practical staff who interact with the patient. And so the CPCA is providing facilitation and these webinars to help bring in that expertise to bridge the gap between the academic and the practitioners. And we also know at the same time that we're introducing these changes to comply with the ACA and meaningful use. There's all these external mandates, but at the same time, you may have had staff turnover, or you may have had a change in increase in the insured population. And so there are internal and external changes happening at the same time. So how do you integrate all these demands? What are the ideas that you have for overcoming these barriers? And it's clear that by participating in today's webinar that you are looking to validate your ideas as well as check out some new ones. So there's a myth that we as leaders who tend to become CEOs of health centers, we have a passion for serving the underserved, but we also have a confidence level that maybe we have something to contribute. And so there's a trap that we can fall into because we're so mission-oriented. And it's that we think we can make sense of all of these complex issues all by ourselves, and that we can not only make sense of all of these complex issues, but that we can impact what our clinic is going to look like in 2014 after the Affordable Care Act is implemented. And the myth of the perfect leader is that we have to single-handedly know how to translate all these regulations into strategies and concrete operations and just give you a list of things that you have to do. But what we know is that this single-handedly administering of a task list also is scary to people. And they are aware of both the internal and the external and can become insecure about their job status. So this research from the Harvard Business Review, Arthur O'Connor, contrasts the complete versus the incomplete leader. So a CEO, for example, understands what their personal strengths and weaknesses are. I know that I am not that accomplished in health information technology. So I know that I need HIT help in order to implement electronic health records. And so I look at my strengths and my weaknesses, and I cultivate others to help me with implementing change. And I also know that I have to delegate, that I can't single-handedly just be the taskmaster, that I have to involve my whole leadership team throughout the organization. And in order to do that, I have to start to look at the strengths and weaknesses of everyone that is on the leadership team, not only the O team of CEO, COO, CFO, CIO, but also the mid-level supervisors and the team leaders at the patient care level. With the model of distributed leadership, there are sort of four key components. One is, how do you make sense of all of the mandates and articulate them? And how do you relate that back to individual levels within and without the organization? And then how do you create a vision for them that shows the desired state to being better in the future than what it is now? And then how do you harness the resources of your team to implement that new vision? So, for example, there are new UDS measures around colorectal screening. So you might look at those new UDS measures and say, how does that fit into patient-centered medical home transformation? How does that fit into meaningful use? What are any HIPAA requirements about colorectal screening and communication with the patient and family or resources in the community? And what's it going to cost to increase our efforts? So you have to kind of go down this checklist and make sense and identify all the relationships that are involved in increasing your activities about reporting out your results of colorectal screening. And then relating, you bring that back to the people side of it. Your patients. Who are your patients? What percentage of your patients are 55 and over and that you need to focus on? Who are the providers that take care of these patients? Who are the staff? What are the staff roles in colorectal screening? And stakeholders, who else is involved? So, for example, very successful model that has been demonstrated at UCSF with Dr. Michael Potter is colorectal screening in conjunction with annual flu shot clinics. That's called the Flu Fit. And so this might be an approach that you want to try to implement. And so you have to look at what do you have to do differently in order to incorporate your annual flu clinics with colorectal screening information. And then, of course, this is extra work, new mandates? Is there additional funding available to help you implement this increased program, i.e. from American Cancer Society? So again, you've made sense of the regulations, you've related it back to the individual staff and providers, and now you can share a vision for the staff of what it's going to look like, in the community. Let's say that your goal is that 90% or greater of your elder population over age 55 are going to have annual flu shots. And so you can communicate that vision into being a total healthier community. And then you take that vision back, and then you're going to incorporate it into your PCHH reality so that implementing increased colorectal screening is not a standalone activity, but in fact one more thing you can do to increase the effectiveness of your patient-centered health home. So we talked about, relationships and what you need to do. So you need to really look at who's involved as you implement each of these new measures. And then, for example, we talked about the relationship with increasing colorectal screening and meeting UDS measures. What do you see as desired impact or future for your clinic with the Affordable Care Act? Where's your clinic located? How many uninsured patients are you seeing now that might become newly insured, and what impact is that going to have? Are you going to be losing patients? Some clinics are fearful with the ACA that some of their patients who are uninsured and will be newly insured want to go elsewhere. So you have to be able to predict that. You have to know whether you're going to increase the size of your facilities to accommodate more patients, or if you're going to need to be cautious and avoid any growth until you know for sure that your patient population is stable. And then how are you going to change your staffing design? Are your uninsured patients primarily young people, the working poor, as we call them now? And if that is, are you going to need more OBGYN care? So what's your staffing model going to look like? And of course, then as we go into patient-centered health home, we're always mindful on the health and the population of our community, and what are we going to do that improves the health not just of our patients, but of the overall community. And then eventing takes it back to doing your research on new approaches, and then taking that research, i.e. what you might be learning from these webinars, and then taking it back to staff and what can you learn from staff and providers. So what approach are you going to use? Well, here's one approach, which is just doing all your homework, making your list. You know what needs to be done. You give the list, and you just give staff a push in the right direction. I liken that to the old Nike motto of just doing it. But that typically, while it might jumpstart, is not a very sustainable way of introducing change that transforms the culture. So for today's teaching example, we're going to talk about workflow mapping. I've had the opportunity to work with the genius and gentle giant, Dr. Thomas Bodenheimer, and his associate, Jennifer Wong, at the Center for Excellence in Primary Care at UCSF. And from them, I've learned some of the techniques about workflow mapping, which is really creating a flow chart of how things are done in the medical practice. And what works about workflow mapping is you don't just talk about it, but it creates a visual map that makes it easier to understand and engage people in more problem solving. And so typically it takes healthcare and looks at it as though it's an assembly line where you have a beginning and you have an end and you have all the steps in between, and you talk about who does what. But what is important to know is that you start with what is right now before you make changes. So there are different levels of workflow mapping. The high-level workflow just talks about the beginning and end point and the key measures. For example, patient arrives at the clinic, they're registered for their appointment, they're seen by the doctor, they leave the exam room, pay their copay, make a follow-up appointment, and go home happily ever after. However, we know that that's not truly how it works, because there's a whole series of incidents and things that can happen that keeps the patient from moving slowly and smoothly through that process. So, for example, patient arrives at the registration desk, but they don't have a picture ID. Patient arrives at the registration desk, but they don't have their Medicare card, or they don't have their Medi-Cal card. patient arrives at the registration desk, they forgot to bring their prescription list, or they forgot to bring their bag of medication pills. So there are a number of things that can happen when the patient arrives that slows down the process. And then that's where with workflow mapping that you start to identify and make a list of the things that can slow down the process and create a delay in the flow and patient satisfaction. There are some classic symbols that are used that I'm sharing here. For example, the green dot, think of go, red, yellow, and green on the stoplight. The green is where you start. You can also think of the green as where you end. So you can have a green dot and the yellow to reflect operation. So we tend to rely on yellow sticky notes as a symbol for the operational points, and then we tend to take those sticky notes, turn them on their side, and use them as triangles to indicate where you have decision points. And then we also have arrows that indicate the direction of activities as they flow forward as they're supposed to, or backward as we hope not, or in a direction other than intended. And there are other forms that you can use to indicate delays in the workflow, or where somebody literally has to go off page. For example, let's say someone comes in and they are a drop-in and there's been no previous screening for insurance or assistance provided in enrolling in emergency Medi-Cal, so they might have to literally go in another room and meet with an enrollment assister. Or an on-page reference might be where the patient can stay there, but that assister comes from another room and assists them. So, and then the big one is unclear, like a cloud. And typically what happens when you're doing workflow mapping, someone will just use a regular yellow or a decision point and put a question mark instead of going to the next symbol. So keep it simple, though. Take your first workflow project and choose a process improvement activity. Now, there are some additional tips and handouts that are available in the links to this webinar, and one of them is a detailed step in designing, which takes in more activities than what are highlighted on the slides here. But pick the simple process improvement activity that can be easily measured with pre- and post outcomes. Because one of the things that's important in engaging staff, that you have to be able to give them a sense of accomplishment. And so if they're going to make changes, they need to be rewarded with information on the positive outcome of those changes. So don't create something brand new that doesn't have the ability to be measured. So I recommend the first time that you go through workflow mapping is that you pick something that you already measure on your UDS reports. And then be sure you pick a project that involves both clinicians and staff. Don't just isolate the receptionists and schedulers by themselves to figure out how to improve no-show rates. Be sure that you involve the whole team, the front office, the back office, the clinical staff. And remember to relate whatever process improvement you choose back to your PCHH building blocks so that you are not isolating your process improvement from your PCHH process. But remember the decision-making tips of how you can delegate decision-making and some of the 4 core components. So go back to that and remember sense-making. Tell them where, let's say, you're going to improve colorectal screening. They need to know where that fits in the overall practice transformation. They need to know how that relates back to PCHH. They need to know what the vision is going to be for the future and how important it is for them to possess input and knowledge that gets back to inventing the new ways of doing things. After that, you need to reinforce that one of the techniques that's proven helpful is integrating workflow redesign. And I suggest that you use workflow redesign not just for one process improvement, that you incorporate it into your culture of guided decision making. And one of the approaches that I have found helpful, as have other colleagues, is the see one, do one, teach one, where you select a pioneer mapping team, a physician and the care team members that are always looking for new things and new ways of doing things, and they're experimenting on their own. So take those natural change leaders and train them first. Either bring in an outside facilitator or send a representative from that already innovative team and have them observe a workflow mapping exercise. Then, once they've observed it or participated in a webinar such as this to get the overview, then have them take that performance improvement activity that they want to work on and do one, meaning go through the process, mapping out a process improvement that's important to them. And then once they have completed that, then take members of that team, schedule another workflow mapping with another physician-led care team, and then teach them so that everyone develops confidence and becomes expert in the guided decision-making process. Now, the initial learning process is ideal if you can have 2 to 3 hours away from patient care, and that's the example in the handout that's provided as part of this, is where you really teach the theory and practice and come up with your implementation plan all in one setting. However, once you've gone through that learning exercise, you can typically do a workflow analysis in a standing monthly staff meeting in less than an hour. It's also helpful, I find, to make it fun, incorporate healthy energy, beverage snacks with these activities. I had the opportunity to work with a dynamic diabetic nurse educator, and she made it so much fun by sharing tips on diabetic nutrition, and we had to eat the food that she was suggesting to the diabetic patients that they ate, i.e. yogurt for breakfast instead of donuts. And so incorporate that as well, where you can start to role model healthy activities as part of your mental learning exercises. And you'll need a wall or a room with long windows. I've used that. That can be stripped of their required posters or pictures or whatever, so that you can mount 8 to 10 flip chart sheets mounted side by side. And even though they cost just a little bit more, what you'll gain in efficiency is if you purchase the self-stick flip chart paper that has the grids on it. Those grids help your flow charts go straight instead of dipping down and pointing toward the floor. And it's very quick to put up another piece with self-stick if you need to. I like to use 4x4 or 4x6 sticky note pads for your coding, because it leaves room for staff to make notes for discussion later. You'll need markers to connect, and blue mounting tape is helpful if you're going to move your flip chart paper to a hallway or break room for later usage and viewing. Again, early success, keep it simple. Don't worry too much about if you're using a cloud for a question, or if you're using the right color or right shape as sticky notes. You can assign someone to record that and make it look official later. You really just want to get staff engaged and make it fun, and just turn them loose and let them use their sticky notes to record their information. Start with a higher level, so get your flip chart laid out with a beginning and an end point, and then and so maybe one flip chart can be the scheduler, one flip chart could be the receptionist, one flip chart could be enrollment or billing, one flip chart could be medical assistants, one flip chart could be physicians, one could be the referral clerk. So pretty much have one flip chart for each person that you have in your expanded physician-led care team. And then they will start to record their activities. I start left to right, where the scheduler is typically the first one, and end on the end with the patient navigator or the referral clerk. So that helps you space out if you start that way, so that you end with the whole wall being filled with equal space. And a critical component is during the early sessions, CEOs, COOs, CFOs, you can't talk. Your role is simply to observe. I had one group where the director of operations had to just practically put duct tape on her mouth because she was listening them to describe a process that she knew was not the way she had written it up. So you'll get your chance later, but initially it's just the frontline staff performing the function that gets to do the recording. And then what's important is have them record together as teams. And so here's an example. See, they've used blue, they use pink for the diagonal. They've got multiple colors going, but it didn't slow them down by worrying if they were using the right code. And this was a couple of receptionists who supported two different patient care teams, and they were comparing notes when they discovered that they weren't quite doing it exactly the same way, and they found that interesting to discuss why he was doing it one way and she was doing it another. And they came up with some new ideas right there just between the two of them by having their own discussion. After you've had the functional care teams, like the MAs, talk about what they found, the schedulers found about what they found, then you get to open it up to the whole team. So now you've got the whole process mapped out, you've got the whole team stepping back and looking at it, and then everybody gets to provide their advice. So here's a couple of physicians talking about, well, you know, I tried this and this is what happened. And so one of the things that really works is peer-to-peer learning. And it's important to, in this case, this was a physician consultant who was brought in to help this organization that was opening new access sites at the same time they had physician turnover. And so they were needing additional assistance with helping the current physicians absorb new physicians and still think of new ways to do things. After you have laid out all of your process steps, then assign a recorder to capture the group knowledge and put it into Visio, or most of the time people are more familiar with just Word and text boxes, and to create a simple diagram to illustrate it. And then I have found it helpful. This was done in a staff break room. And so once you've taken, I use my iPhone to take pictures of it to save it. And then once you've got it there, then staff are invited to start rearranging the sticky notes to add new steps. So here where they use yellow, they might use a different color sticky note to indicate a change in their process. So they can literally start moving the sticky notes around to facilitate discussion on how it might be done differently. What's really helpful is if you can involve staff right away in developing the corrective action plan. I I had the luxury with one of the clinics that we worked with where they gave us the entire day. And we spent half a day doing workflow mapping and some role plays, and then they had lunch, and then they came back and implemented this very detailed work plan, which was complete by the end of the day. And they decided on what quick fixes were going to be that they could do that day, the week, and within the month. And so that was a very dynamic work group to work with. And remember, don't incorporate a lot of new changes that refer back to your traditional plan, do, steady act model, which means this is what we're going to look at for performance improvement. These are some of the changes that we're going to do. Then we're going to study and see if it worked, and then we're going to come back and modify it if we need to. So here are a couple of examples from some of the pictures I shared earlier of work groups that use the simple workflow mapping process. One group chose the UDS measure of increasing pediatric immunization rates. And their immediate one-day success that they all agreed they could do because they had a new electronic health record is they could pull out a list of all pediatric patients and identify whether they were or were not current with their IZs. And that they would take that list and they would divide it up and they would call all the parents within that first week and notify them of the need to bring their child in to get current on their IZs. And then this group, remember we talked about new ideas or inventing and innovation, this very involved dentist who had a very active pediatric dental practice said, well, why don't I ask the dental patients if they're current on their IZs, or if we could check that for them while they are here getting their dental care needs taken care of. And in this clinic, the dental practice was next door in a separate building, and they decided that they would literally do a warm handoff or escort the patient and parent from the dental to the medical. And then the primary care physician leader wrote standing orders for patients that were in the practice, where the charge nurse and the medical assistants with these standing orders, if they were already patients in the practice, could receive their IZs without first having to see the physician for a same-day appointment. And this was very important because this was a rural clinic where a large number of their patients got to appointments by a bus, and so it was not easy for them to come back for another appointment. And so I thought this was a very exciting conclusion and a very specific action plan that I think is a best study, a best practice that can be emulated. In a totally different clinic in a more urban environment, they had a different challenge. And the champion here was the physician leader for the clinician of the lead physician on the one pioneer team. And so after they did the workflow analysis, they discovered several things, and these are some of the things that they came up with. First, one of the backlogs in completing referrals was that the sole referral clerk was spending a lot of time trying to notify the patients and confirm them of their specialist appointment, and she could not complete the referral process and move on to the next one until the patient has been notified. And because we had the whole work team in the group together, the receptionist said, well, you know, we know these patients. We're checking them in. We're making appointments for them to see our clinicians. Why can't we call them back and say, voluntarily took some of the work off of the desk of the specialty referral clerk. Another thing that they identified in this group discussion, that sometimes referrals would be made or phone calls placed and they wouldn't call back, that the referral clerk would leave a message for this specialist and nobody ever called back. And so she was wasting her time placing calls to people who no longer accepted referrals. And the physician said, well, I could have told you that. So-and-so moved his practice, 3 months ago to another group. And so the physician volunteered to go over the referral list and to update it with information that he possessed that had not gotten passed on to the support staff member. Another barrier that was identified in the mapping process is that the specialist sometimes had requirements that certain laboratory tests or radiology exams had to be completed before the patient came for their specialty appointment. And when when a referral clerk would follow up with the patient trying to figure out the status of their referral, she would be told, well, I haven't gone yet because I couldn't afford to get this lab test done. And so they decided that that was a significant number of their patients with limited resources and without insurance that were staying in the primary care practice because they couldn't afford to go to the specialist and get these tests done. So they decided to look at the tests that they could offer there in the community clinic and see if there are a couple additional lab tests that are blood tests or urine tests or whatever the required tests are that they could do themselves there at the clinic and be ordered by the primary care physician at the time this patient was there, so as to have them ready for that appointment with the specialist. Now, this wasn't a 1 day or 1 week because this required the new changes in lab billing, and this was probably a 3-month performance improvement. But yet it was a very concerned and caring way to try to make it easier for these patients to get the care that they needed. And it had the positive impact of opening access, because once the patients are handed off to the cardiologist or the endocrinologist and are followed by the specialist, then that makes room for new patient appointments with the primary care physician. Another solution that this team decided to do, which almost seemed counterintuitive, they decided not to spend a lot of time on creating a tracking template in the new electronic health record. One, their HIT department was feeling overwhelmed with all of the template changes, and two, the time it would take was somewhat extensive because there were other initiatives ahead of it. So the referral clerk agreed to just keep a temporary paper log to keep track of when she received the referrals, when she completed the referrals, and paying special attention to those that took longer than 10 days. So with their PDSA cycle, they would come back and then they would look at just those referrals that were taking longer than 10 days to accomplish. So when we talk about sustaining change, because remember the focus of today's discussion is engaging staff through distributive leadership so that you're not just making a one-time change, but you're really transforming the culture and transforming the practice. So, it's easy to get people involved to, give them 3 days off-site, give them healthy food, let them have fun talking to each other. The workflow process is fun to do. That's a fun activity. But it's a little harder to maintain that enthusiasm and maintain those changes. So there's another resource that's available, which is the call Qualis Implementation Guide that I want to refer you to, and it's called Elements of Engaged Leadership, because in order to have engaged staff, you have to have engaged leadership. And so the transformation, is not just one way. It has to be ongoing, and it has to involve a culture. And so here are some of the things that we know that leaders have done that make a difference. One, the leadership has to be visible and sustained. You just can't have this one-time meeting where the CEO shows up and says, here's our new practice facilitator. She's going to be here to help you do what we need to do in order to get PCHH certified. The CEO introduces the facilitator and leaves the room. That does not show a high level of commitment. So what's important is that the CEO be visible throughout the change process, and that expresses concern about how it's going, expresses support, great job, way to go, I'm so proud of my team, you're all doing a great job. So the CEO or the top leadership has to stay visible, and they have to sustain their support. And so one way of sustaining support is saying that this isn't just an add-on to the other activities, but this is so important that we're going to do a special task force to help us get jump-started with implementing these workflow analysis. And here's our pioneer team that's going to have the special training, and they're going to help develop the benchmark measures, and we're going to report back out so that you know how well you're doing. So that ongoing team that's going to lead the work on a day-to-day operational basis is very important. Also important is to be sure participants have protected time. And my work with PCMH coaching, I think this is one of the things that I hear more frequently. Well, I'm already part-time, and now they've given me this extra job. I don't know how I'm going to get my regular job done and do all this additional work. So you have to somehow recognize that going through a transformation process like electronic health record implementation or a significant process improvement takes extra time. And yes, it does initially cost you productivity, but it will eventually increase productivity and efficiency. So you have to make time in order to save time. And then know that you're building a new concept of patient-centeredness and patient-centric, and so build that into all your staff development and training and into your new hiring process. So in summary, some of the things that we've talked about is to pick a change management planning process as a guide. One approach that doesn't work is keep them guessing what the CEO is going to do next. I have an example of one organization that I worked with, and the clinician leader was fairly new graduate. And so each monthly staff meeting, he would roll out what the staff dubbed the Management Book of the Month Club tip. So every month he'd read a new management book, and every month he'd roll out a new idea. My suggestion is pick a model and stay with it. So this article that I've shared with you, or the tips on distributive leadership, is from Harvard Medical Review, 10 Best Practices. It's actually available in a paper book, and I was so surprised on the last trip I took. It was in the airport bookstore, but it's also available from the Harvard Business Review. And it's like 10 little short, quick reads on best leadership practices. And I think that this one is a very simple model so that you can communicate with staff. This is the process that we're going to use instead of keeping them guessing, what are we going to do next? Then use workflow mapping or other games, exercises, communication activities that make it safe. Suggestion boxes are old, tried and true ways. As long as staff know you look at and their ideas are considered. What doesn't work is a suggestion box where there's no feedback and staff never knows what happened to their ideas. So be sure that you keep everyone engaged and give them feedback on their ideas and reward, best idea of the month or something like that. Be sure that you enlist the physician support by bringing in best practices. Let them know that you aren't coming up with these ideas off the top of your head. And it helps to reference materials vetted by other physicians. For one example, one of the items that I recommend on the Advanced Medical Home Patient-Centered Physician-Guided Model of Health is published by the American College of Physicians. And so that is listed as a resource for you to share because it's helpful. Physicians like evidence-based and peer-to-peer information. And don't be embarrassed to ask for help. Don't fall into the trap of becoming the complete leader where you think you have to know it all and do it all and be all things to all people. But take advantage of outside resources to help facilitate your transformation, such as those being provided in these webinars or coaching facilitation by one of the CPCA practice coaches. And I can pretty much guarantee I've never seen a failure where a leadership team tackled a practice transformation with a comprehensive approach that did not result in positive outcomes. So if you can share your vision, involve everyone, then you are likely to be one of those CEOs that has an engaged care team that is working and singing in harmony, much like this picture that I found, which just makes me smile.